Hi, today I will be starting with the lectures on gastrointestinal disorders. As esophagus is the first part of gastrointestinal symptom, I will start with esophagus. The commonest symptom which I will discuss in my first lecture here is dysphagia. Dysphagia is abnormal sticking sensation in throat, in retrosternal region and epigastrium during act of swallowing. This is one of the most commonest symptom which is seen in patients who attend OPD. Now whenever a patient comes with history of dysphagia, how to proceed? In this lecture, I will let you know how to do the clinical approach in a case of dysphagia. So whenever a patient comes with history of dysphagia, first of all, you will have to decide about which stage of dysphagia is there in this particular patient. There are various stages of dysphagia. First stage of dysphagia is whenever a patient is having any problem in first stage of deglutition. What is the first stage of deglutition? It is the movement of bolus from oral cavity via pharynx into esophagus. This is the first stage of deglutition, first stage of swallowing. Second stage of deglutition is passage of bolus through esophagus down towards stomach. So whenever there is any problem in this first stage of deglutition, that is passage of bolus from oral cavity to esophagus via pharynx, we call it stage 1 dysphagia. Whenever there is any problem with passage of bolus through esophagus, that is stage 2 dysphagia. And whenever there is any problem of passage of bolus from esophagus down into stomach, that is the third stage dysphagia. Usually patients who are suffering from first stage dysphagia, they present with abnormal sticking sensation in throat region. So these patients, when they come to you, they will say that they are having sticking sensation, obstructive sensation here in throat during act of swallowing. So this is how you will decide about first stage of dysphagia. If patient says that he is having problem here in the retrosternal region during act of swallowing, that is known as stage 2 dysphagia. And whenever a patient says that he is having some sticking sensation in epigastric region or lower down in xiphisternal region, then we'll say that this is stage 3 dysphagia. So that is how we classify dysphagia into three types: stage 1, stage 2 and stage 3. So whenever a patient comes to you, first decide what is the stage of that dysphagia. With the help of stage of dysphagia, you will come to know about site of pathology. Where is the disease situated in the esophagus? Then, in the second step, you will have to decide about severity of dysphagia. How much severe is the dysphagia? Now, the severity of dysphagia is classified into four types. First is grade 1 dysphagia, that is intermittent dysphagia, that is not present all the times. Sometimes it is present, sometimes it disappears. Stage 2 dysphagia, that means a dysphagia which is present but it is relieved with a simple effort during act of swallowing, that is stage 2 dysphagia. In stage 3 dysphagia is relieved during act of swallowing while taking meals with just a glass of water, that is grade 3 dysphagia. If bolus is not at all passing down, that is absolute dysphagia. We can also say that it is stage 4 dysphagia. So like this, we grade the dysphagia: grade 1, grade 2, grade 3, and grade 4. In between, I have said stage. That is not stage, it is grade, severity. So severity is like this: you decide severity while you talk to a patient. Now, whenever a patient comes with such feature of dysphagia, in the second step, you will have to decide whether this dysphagia is acute or it is chronic. Now, the causes of acute dysphagia are altogether different from the causes which are there of chronic dysphagia. While patient comes to you with acute onset dysphagia and it disappears, this type of dysphagia is usually noted in motility disorders of esophagus, in acute inflammatory disorders of esophagus. The usual causes of such type of acute dysphagia of acute dysphagia are: number one is foreign body ingestion, usually in pediatric age group. In patients with psychiatric disorders, they may develop acute dysphagia because of ingestion of some foreign body. After ingestion of a huge bolus, sometimes patient may develop acute dysphagia. Acute dysphagia is usually seen in young age group, and in young age group it is because of motility disorders. I mean to say that acute dysphagia in majority of cases is because of acute motility problem. Now these acute motility problems, that means problems in motility of esophagus, these are: number one, the most common one is diffused esophageal spasm. This diffused esophageal spasm is precipitated as soon patient ingests food material, and this is usually seen in young patients who are very aggressive in nature, who are suffering from anxiety, severe anxiety, while taking meals. If they are quarreling with each other, then in that case, this diffused esophageal spasm is precipitated. In diffused esophageal spasm, whole of the esophagus contracts at once, as a result of which there is sudden obstruction of bolus in the esophagus. This type of diffused esophageal spasm, sometimes it simulates acute coronary syndrome. So it is a must to differentiate it from acute coronary syndrome. The second common cause of acute dysphagia is local esophageal spasm. Again, local esophageal spasm is simply a variant of diffused esophageal spasm. So, if a young patient is there, if he is anxious, he is suffering from anxiety, if they are quarreling with each other while taking meals, then usually this type of dysphagia is precipitated because of diffused esophageal spasm. Another condition is there which is known as hypertensive lower esophageal sphincter. In this hypertensive lower esophageal sphincter, the lower esophageal area, which is known as sphincter, lower esophageal sphincter, as such, there is no sphincter in lower esophageal area, but the area of lower esophagus, a part of cardia, angle of cardia and esophagus, that is known as lower esophageal sphincter. So this area, tone of this area is increased during act of swallowing. This is, again, we can say that it is also a variant of diffused esophageal spasm. So there will be a sudden contraction in this lower esophageal area during act of swallowing, and patient will develop dysphagia. And he will usually complain of sticking sensation in epigastric region during act of swallowing. So whenever a patient reaches you with such type of acute dysphagias, the main thing which comes into your mind is diffuse esophageal spasm, lower esophageal spasm, hypertensive lower esophageal sphincter. Another motility disorder is hypertensive upper esophageal sphincter. Again, in this disorder, there is sudden contraction of cricopharyngeus muscle. Cricopharyngeus muscle, this muscle in this area, is hyperactive. During act of swallowing, it suddenly contracts and patient develops dysphagia. He will say that he has sticking sensation in the region of throat. In this region, he will have sticking sensation. So this is upper esophageal hypertensive upper esophageal sphincter syndrome. So these are various motility disorders which are usually seen in young age group. Their presentation is acute. These are motility disorders. Motility disorders means there is disorder in function. As such, there is no pathology in esophagus. Only function is impaired. Second, in elderlies. Sometimes elderlies continuously complain of sticking sensation in throat while act of swallowing. This motility disorder in old age group, you can say that it is variant of diffuse esophageal spasm in elderlies. But in this, force of contraction of esophagus is relatively slow. It is not so powerful. This is known as press by esophagus. So these are the various motility disorders of esophagus which are seen in the clinical practice. So whenever a patient presents with such type of dysphagia, acute type of dysphagia, if he is young, he is an anxious person, then one must always rule out these motility disorders. Second cause of acute dysphagia is acute inflammation of esophagus, acute inflammation of pharyngeal region, acute pharyngitis, that is because of acute infections, acute allergic reactions. So in these conditions also there is acute type of dysphagia which is relieved after medication, with relieved after taking antibiotics, decongestants. Acute type of dysphagia is also seen if a person has ingested a foreign body. This is usually seen, I have already said, that in people who are suffering from psychiatric illness and children's pediatric age group. So these are the causes of acute dysphagia which usually come in OPDs. Then if a person is presenting with chronic type of dysphagia, acute dysphagia is, we can say that it is the dysphagia which is present within 10 to 15 days of onset, that is acute. So if duration is more than 15 days, it is persisting, that is chronic dysphagia. Now this chronic dysphagia, it can be again in stage 1, that is in the stage 1 of deglutition, stage 2 of deglutition, or stage 3 of deglutition. In 3 types of this chronic dysphagia may be present. Now these chronic dysphagias are usually because of some intrinsic compression, intrinsic growth, some extrinsic growth, or some pathology in esophageal wall. So we can say that chronic dysphagia can occur because of some extrinsic compression of esophagus from outside, or some pathology in the wall of esophagus, or if there is some mucosal reason in intrinsic lesion. Usually the chronic dysphagia, if it is occurring, is usually because of growth. I mean to say because of carcinoma esophagus. And this carcinoma esophagus, any type of carcinoma esophagus, can produce this dysphagia, and this dysphagia is gradually progressive. It doesn't progress rapidly, it is gradually progressive. So a person will come to you with history of dysphagia, and he will say that at the beginning this dysphagia was of grade 1, that is it was intermittent. Later on, it became of grade 2, that is, it was relieved while act of swallowing by itself. And in grade 3, it was relieved after taking sip of water, and it is absolute dysphagia. So it gradually progresses from grade 1 to grade 4. This dysphagia is usually because of growths in the esophagus. Usually these growths in esophagus, carcinomatous growths in esophagus, are seen in tobacco chewers. So if the patient is tobacco chewer and if he is presenting with dysphagia, always go through the investigations to rule out carcinoma of esophagus. Sometimes, if there is chronic reflux esophagitis, there is chronic GRD, gastroesophageal reflux disorder. In those cases also, many a times there is development of adenocarcinoma at the lower end of esophagus or somewhere in the middle esophagus, which can cause carcinoma. So in these cases, to begin with, in history, you will get history of reflux for a long time. Gradually, the patient will say that reflux had disappeared by itself for a few years or few months, and then he started developing dysphagia, and then dysphagia progressed. This suggests that previously there was gastroesophageal reflux disease, and which has developed this carcinoma because of chronic reflux and irritation of esophagus. So carcinoma is one of the causes of chronic type of dysphagia. The second cause of dysphagia is strictures. Now, these strictures usually develop in chronic inflammatory disorders of esophagus. If there is chronic inflammation of esophagus for a long time because of gastroesophageal reflux disease or chronic esophagitis, that may lead to stricture formation. Another most common cause of stricture formation is acid ingestion. Because of suicidal tendencies, many people they ingest acid, and this acid later on produces strictures in esophagus, and gradually the patient will develop chronic type of dysphagia. So like this, these patients of chronic dysphagia will present. So whenever they come in the OPDs, you will have to work on these lines. On the other hand, if patient suppose he is having some chronic type of inflammation, again they can present with chronic type of dysphagia. Usually a patient of candidiasis of esophagus, esophagitis, candidal esophagitis, they present with chronic type of dysphagia. It is many times the chronic type of dysphagia is because of some extrinsic compression from outside. Now, what are the causes of extrinsic compression? Extrinsic compression can occur because of any mediastinal pathology. Suppose if there is some mediastinal tumor, mass, growth in mediastinum that will compress esophagus from outside and will produce dysphagia. If left atria is large because of mitral stenosis, nowadays it doesn't happen because surgical interventions are present, but in past years, 3 decades, 4 decades back, left atria used to enlarge and compress esophagus from behind and cause dysphagia. So any pathology from outside, either mass or if there is mediastinitis or any type of pathology which is compressing esophagus from outside, that can produce dysphagia. So like this, if patient is presenting with dysphagia, you will have to decide whether it is motility disorder or there is some pathology in the mucosa or there is pathology in the wall or there is extrinsic pathology in the mediastinum. Now when these patients, they present in the OPD, what investigations you will have to suggest these patients? Any patient who is presenting with dysphagia must undergo upper gastrointestinal endoscopic procedure. With the help of endoscopy, we can diagnose the lesions present in esophagus whose about the sensitivity of which is about 99%. So this is the diagnostic procedure, endoscopy, 100% diagnostic procedure which should be performed in any patient who is presenting with dysphagia. You can diagnose, you can take biopsy for histopathology via the endoscope. If whole of the esophagus is normal, if there is no pathology, then you will have to go further for studies of motility disorders. You will have to undergo studies for measurement of pressure in esophagus. So the first investigation, which is diagnostic, is upper GI endoscopy. Second one is manometric study of esophagus, in which pressure is measured in esophagus during act of swallowing. These two procedures are diagnostic. Now, if you think there is some extrinsic pathology in the esophagus, then that extrinsic pathology can be diagnosed with the help of CT scan of chest, which is diagnostic. Simple X-ray can even sometimes lead to a diagnosis. In past, when no endoscopic procedure was present, there was no CT scan. In that era, barium studies were done in cases of dysphagia. Now, this barium study is a triphasic study. In this triphasic study, barium is given, and then in the barium is given, and then X-ray is taken, and in X-ray we see the site of lesion. In second phase of this barium study, you give aerated barium, that is barium dissolved in soda. This produces air phase in the esophagus, and mucosal details, they become available. So this diagnostic procedure is having sensitivity and specificity of about 60 to 65%. So it is not diagnostic procedure. Endoscopic procedures are best diagnostic procedures. So like this, we proceed in investigations of esophageal pathologies producing dysphagia. In the next lectures, I will gradually move on to the different diseases of